For this first part of the presentation, we're going to talk to you a little bit about the transition that we've made to the clinical doctorate and some of the reasons why we decided to make that change. We're going to talk to you specifically about the doctoral experiential component. And then we're also going to talk a little bit about opportunities that we think that we have within current healthcare educational community settings for some of these doctoral experiences. So why did we do this? Some of you might be asking. We literally wrote the book on it. Well, not really, at least the article on why we thought that it was important to do. And so here at Ohio State, one of the big things that we recognized when we were trying to decide to do this or not to do this was to really look at our curricula and to look at the education that we were providing students. So if you got a master's degree here at Ohio State, you had about, depending on the year of your degree, 75 to 80 credits as a master's degree student. At Ohio State, a doctoral degree is 90 credits. So when we had a retreat to decide what we thought we should do, one of the people that's in charge of curriculum for the university kind of led us in that retreat, and that was the first slide he put up. A typical master's degree at Ohio State is about 40 semester credit hours, so our students were really doubling what a typical master's degree would be. So he said, you have me for the day, but as I see it, you're really, at this point, practically giving your master's level students a doctoral experience education. So his thought was, that's what you should be doing. So we debated on that, and we chose as a faculty to do that. And so you're going to get to meet some of Rebecca, one of our first OTD students. So why did we decide to do that? I think all of us in healthcare understand that in a lot of ways, things are getting more complicated. Would you agree with that? So how many have worked at DOD through the years? Raise your hands high. We didn't have like DOD alumni, right? You should have, or DOD support groups, I guess, for alumni, right? So if you think about someone that had a spinal cord injury that came into DOD, Bobby was a wheelchair vendor for Columbus Medical for a long period of time. I think when he first had his injury about 30 years ago, I think he was at DOD for over a year, maybe almost 2 years, because he was one of the first people to live here on campus. What's our average length of stay for somebody with a spinal cord injury these days? 2 weeks, 3 weeks, 4 weeks if we're lucky. So what does that mean? It means that we are now treating people without the same level of medical support that typically we had, with Bobby at DOD, 30 years ago. So we think that we're starting to practice a little bit more autonomously as professionals, and we need to make sure our students and our new graduates have that training. It's more important than ever that we're able to collect evidence and to use evidence in our practice, because our reimbursers expect that, right? Is that true for everybody in practice right now? Pretty much so. The other piece is really to make sure that we're looking at clinical guidelines so that we're, as best we can, trying to follow guidelines so that people with similar conditions are going to get similar types of intervention and hopefully with similar and improved outcomes. And also that it's really important for us to have leadership within teams and to be able to be really active members of treatment teams. So that's not to say that we aren't always already doing that as occupational therapists, and we weren't doing it when we were preparing bachelor's degree students or master's degree students, but are there ways that we can really even improve that on another level? So we've made some pretty significant changes to our curriculum. We are hands-on quickly. Not the first semester. The first semester, they still do cadaver dissection anatomy, but we added the head and neck, so we're really excited about that they get the head and neck now. We've had some transitions in faculty. So Jane passed away, Melinda Ripsky, Meg Tiefert, and Sharon Flynn have all retired. So we've brought in some new folks, and so Lisa Juckett is one of the people in the back. You want to say hello, Lisa? Lisa's our certified hand therapist and teaches orthopedic. Is Christine's out working, I'm sure. There you go. So Christine Griffin and Lisa Juckett we're both at DOD, and so they teach a lot of our really physical function, hands-on types of skills. So it's great. They're bringing some of the patients that they have within the neuromuscular lab that they're part of. So our students, we're bringing 6 to 8 folks in, and our students are doing evaluations really at very early courses. So we're really excited about that. Erica Kemp is in the room as well. You want to say hello, Erica? Erica is our new academic fieldwork coordinator. So let's give Erica a nice round of applause. We always have to So answer when she sends you an email, please send that email back. Oh, good, good, good. Yeah, we're always, this is a free CEU, but we like when you answer our email. So anyway. And then other folks, Steve Page is here. I'll show you pictures here in a sec. Anyway. But the really nice thing is that all of us to some level have clinical practice within what we do. So my position, for example, I'm half-time on faculty, and half of my position is over at the Nice-Unger Center now. So we all have some level of patient interaction, which is great for our students. So our three curricular threads that we're really focusing on is excellence in clinical practice. No matter what we do, that's the bottom line. We need to make sure that we are producing graduates that are excellent clinicians. But as part of that, they have to be able to translate evidence into practice. And then also, obviously, professional development and leadership is important. And so that's just a little bit of what the numbers look like and when courses happen. So other things that, again, hands-on very early. We use the standardized patient lab as part of the College of Medicine every semester. Our students love it. Our students hate it, actually, because they're videotapes and they get feedback on how they did. So especially that first time, there's usually one or two students that might have a bit of a tummy ache beforehand, but we haven't lost any students as part of the clinical simulation, so that part's good. We also continue to have extensive labs, fieldwork throughout. We've also added advanced topic courses in pediatrics and in neuro, but with our change to the curriculum, about 75% of what we've added is this doctoral experiential component. So what is the doctoral experiential component? I know you're dying to know this, right? And you're not here for ethics. You're here for the doctoral experiential component, right? Absolutely. Very, very much so. So as you look and see what are the students that we're producing, how many of you have master's degrees from The Ohio State University? So congratulations, all of you. Thank you for being here and continue to support your fine university. So basically the vast majority of the classes that you had have been shrunk. We were able to add some content that was important. We were able to kind of move some content around that we figured out we were teaching, and you may be able to tell this 3 or 4 different times, and maybe we would do better if we taught it twice instead of 3 or 4 different times. So if you look at basically everything through autumn of year 2 is almost all of our master's curriculum. So we've shrunk that down, and then students go and they do their level 2 field work. After they do their level 2 field work, so right now Rebecca, and did I see Jordan? Oh, hi Jordan, there's Jordan in the back. Oh, Jordan, we don't have a seat for you. Anyway, so you guys are in what week are you in a field work? Week 3 of field work, second rotation of their field work. So they'll be done with their level 2 field work around July 1st. They get a little bit of the summer off, and then they'll start back with us in the autumn, and they'll be with us for about 11 weeks of that intensive neuro, intensive pediatric course if they're interested, and then also a management course and a consultation course as they're continuing to refine the work that they're going to be doing in their doctoral experience. And then they start their doctoral experience this December, and they'll be talking to you here in a bit about what exactly they'll be doing. Okay, so Dr. Dare and I were up at the Cleveland Clinic a few weeks ago. And so the Cleveland Clinic is one of our great partners, as many of you are in this room. And so they got a request from a newer doctoral program outside of the state of Ohio that they asked for a 16-week doctoral experience, a 16-week fieldwork experience for their doctoral student. So they reached out to Erica and I saying, what does that mean? So I think it's really important for us as a profession, at least on the academic side, is to really differentiate fieldwork from the doctoral experience. They're not the same thing. They're really very, very different. So it starts with the goal of each one of them. So the goal for level 2 fieldwork is really to develop an entry-level, competent generalist. That's the goal. And so by the time our students come back from their level 2 fieldwork, so from our understanding, Rebecca and Jordan will be at entry-level competence after level 2 fieldwork. They'll come back, get a little bit of polishing, and then we'll send them back out for their doctoral experience. The goal of the doctoral experience is to develop advanced skill in one particular area that is beyond the generalist level. I didn't write the standards. I just have to try to follow them as best we can. So what does that mean? We had a clinical council meeting last year, and as we were preparing for our, we had 2 ACOTE site visits last spring. So if we all looked a little harried here at OSU last spring, it's because we were more than a little harried last spring. And so as we were talking to a lot of our fieldwork educators about that, and so what does that advanced skill beyond the generalist level mean in each of the different practice settings? So one therapist in particular at Riverside talked about how at Riverside at that time they were really looking at visual assessments for people that came in with neurological conditions. So that was the question they had. What's the best visual assessment to do with specific types of stroke? So as we talked about that, wouldn't that be a great potential doctoral experience for a student, so that they would have some clinical experience within acute care? We can't expect that a new grad is going to have advanced skill in acute care generally, but within one little narrow scope of acute care, we think they probably can develop some level of doctoral experience. That makes sense to you? Okay. So other things that are different from the doctoral experience, I'm going to have to put my glasses on again. So I'm sort of in denial that I wear glasses. So the more I talk about it, I think the more I'm going to be able to accept the fact that I wear glasses. So differences between fieldwork and the doctoral experience. Specifically, Erica Kemp is in charge of fieldwork, and I help to supervise the doctoral experiences. For fieldwork, we have fieldwork educators. For the doctoral experience, it's a site mentor. So you see how that's a different relationship, and we expect that the relationship is going to be different at a doctoral level than it is at a fieldwork level. The time frame is different. For fieldwork, it's 12 weeks. So when that program called and asked the Cleveland Clinic for a 16-week fieldwork, what they were actually asking for was a 16-week doctoral experience. So again, really important for us to differentiate what those two things are. The credential of the supervisor for level 2 fieldwork has to be an occupational therapist. Something that's different for this is that for the doctoral experience, it doesn't have to be an occupational therapist. So there might be some situations where it might be appropriate to have someone else that has a level of expertise that isn't an occupational therapist. So for example, my wife, I'm always a fieldwork educator. I will never stop. I'm always an academic fieldwork coordinator. I'll never stop being that. My wife fell, and we ended up at OSU's ER, and she was treated by the doctor seeing her was the lead gerontologist for the emergency department. So we started talking. I said, hey, I understand you have OTs and PTs here in the emergency department. What do you do with that data? And she's like, well, you know, we look at it, but it would be great if we could figure out a way to really, really look at that data. And I said, so we have these students, and would you be interested potentially in a doctoral experienced student what a great experience for the student that could work with the physicians, could work with the OTs and PTs in that emergency department, could really look at data, you know, what are people's outcomes? You could also do all sorts of fun things that are difficult a lot of times to be able to do or bill for. So how great would it be if then that student could follow the patient up and go and do a home assessment? Why are they falling? You know, a lot of things that an emergency department maybe you refer out for, but how great to have that data and be able to follow that data. So we think there's tons of synergy and tons of potential for that. In terms of caseload productivity for fieldwork, the goal at the end is that you're going to be basically the equivalent of a full-time employee. Depending on your setting, the goal for the doctoral experience is not to build up that full-time employee productivity level. Does that make sense? So it really is, what are these other things that a lot of times we're limited by reimbursement issues, by staffing issues that we don't have the opportunity to do. But this is a student that's going to be able to develop some of those additional skills. Fieldwork is all 100% of the time is on site. The doctoral experience 80% of the time is on site. So they can do 1 day a week at home. We have some students that are going to be one in Ecuador, for example, that's going to be doing part of her time here, getting ready for that, and then the other part is on site. Duties are going to be a little bit different. So typically for fieldwork, it's clinical care, but again, for this doctoral experience, it's much beyond that. So clinical care might be a part of it, but it might not be, just depending on the setting that they're And then the learning objectives are much more student-centered for the doctoral experience. So other professionals, again, that might have some ability to mentor students, you can kind of see who that might be. And so part of the standard is that we deem that the site mentor is competent to do what they're being asked to do. So typically we're going to think that they're going to have a license or some type of national certification, but there might be some people that just have a really high level of expertise in a particular area that we can demonstrate that they have the ability to be able to supervise students. So one thing that's really important for us, we're still lucky to be pretty, we have enough fieldwork sites here for our students, and that's not true in a lot of different parts of the country and even different parts of the state. And so one thing we have to be really careful of is trying not to take fieldwork sites and turn those into doctoral experiences. So it's great to see some folks that may not be able to typically supervise a level 2 student. So it might be a manager, it might be someone that works in HR as an occupational therapist, that it probably isn't the best fit to supervise a level 2 fieldwork student, but might be a great fit to supervise one of these, or I'm sorry, to mentor one of these doctoral experience students. So is anyone here from the licensure board? All right, we'll talk about them. I'm just kidding. Mary Stover is here, and she's a retired member of the licensure board. Little secret, I don't know if it's still true. It was true a couple years ago. Every member of the licensure board was an Ohio State graduate. Is that still true, Mary? It was 2 years ago. There you go. That's right. So anyway, so we believe in the licensure board, and we absolutely want to follow what they're doing. So the important thing is for these doctoral experience students, are they billing for occupational therapy services? Are they providing occupational therapy services? Are they calling it occupational therapy services? If that's what's happening, then at that point, it certainly needs to be supervised by an occupational therapist. So the example in the emergency department, you know, there might be some things that they're doing that have a real clinical component that need to be supervised by an occupational therapist, but there might be other aspects of things that they're doing that will not need to be supervised by an occupational therapist. Okay, so ACOTE says that our doctoral experience needs to be part of our curriculum. And so, and you can do a doctoral experience in one of 8 areas. So these are the 8 areas that are prescribed by ACOTE. So that being said, we don't have a lot of students that are dying to do theory development. Anyone here really want to do a theory? Because, you know, we could create another frame of reference. That would be fabulous if we had another frame of reference. So that being said, and especially because of who we are, and really our interest is in producing phenomenal clinicians. And so because of that, we're really focusing on 2 specific areas. One is to look at clinical guidelines, clinical pathways, and the other is looking at program development. So that being said, we're really trying to push our students as much as we can into clinical pathways. And so what a great resource potentially the student would be for you to help you and your organization to develop some of these clinical guidelines, clinical pathways. What is it, Kelly? Best evidence statement? Nationwide calls it best evidence statements. Is that, yeah, there you go. One of those, yeah. So, yeah, there you go. Excellent. So whatever your organization calls it, we're happy to call it whatever your organization calls it. But provides a great opportunity. This is a really outstanding student. One of the classmates works in a lab with me, and so she's in the midst of her second level 2 fieldwork, and I gave her some chart reviews to do, and it was phenomenal. It was as good, probably better than the chart review that I would do. Like just really, really, our students are incredibly impressive, and I think are doing a phenomenal job out there. So those are the 2 things that we're trying to do. If they're really interested in doing any of the other options, so advocacy, working with OTA, working with AOTA, we can support that to some level. So for us, what does this doctoral experience look like? And how does it relate to other requirements at Ohio State? So the doctoral experience is that 640 hours of time that students have to perform in terms of what they have to do for the doctoral experience. Within that, there's also a written component that meets the requirements for Ohio State's requirement for a doctoral degree. So that we call here at Ohio State the capstone, And so that's the written part of that. So whatever the evidence is that they're using to develop that clinical pathway, so that, though, is just a small piece of it. So again, when you think about that, the student that is at Riverside in acute care focusing on visual assessment, that's going to be their capstone. The 640 doctoral experience is bigger than that, can encompass lots and lots of different things in acute care. Does that make sense? Okay. So scheduling possibilities, our students are out from December 1st-ish to about April 1st-ish. There's some play in that, especially students that go international for that. The requirement is that 80% of it has to be on-site for that student. Some other things, you can look at it this way. So this might be what a student's typical week would like, so that they're on-site 32 hours a week and off-site 8 hours a week. Another student might just be different depending on the week of the experience that they're on. So some might have that same schedule every week. Some might be on-site more at the beginning and off-site more at the end. So for us, what we're aiming for in this clinical doctorate is that we're going to have students that are excellent in clinical practice. They can effectively translate knowledge to practice, professional leadership in practice, just kind of the basics of what we expect of fieldwork students and students, and really human beings in general, that they demonstrate good professional behaviors, ethics, and standards. And so in addition to those, the student and the site mentor collectively are going to create 3 things that are going to be specific to their doctoral experience. So in terms of what is this interaction between the different folks who are involved in this, so my name's up there. So I'm sort of the administrative person that makes sure that contracts are there, that assessments are completed, evaluations are completed on students. The student is there, so they're going to come to you with their ideas, but also what we're trying to do today is to recruit your ideas so that we can have a pool of 30 or 40 ideas of doctoral experience options for our students so that we can propose those to our students and match you with a student who's really interested in what you're interested in. The other part, or the other person that's part of that is one of the faculty members, serves as a faculty mentor, faculty advisor. Their job really is to connect the student to that capstone, so they'll have some area of expertise related to what the student is aiming to do. Site mentor is responsible for completing an online module, so understanding what supervision is. So those of you that have been fieldwork educators, you kind of know the role with that. Collaborating with us, scheduling students, evaluating students, making sure the students' hours are accurate. Faculty advisor, again, is really about making sure that the capstone is up to par. And really the nice thing about that potentially is that within your setting, you have access to faculty as well. So how cool would it be to have access to the leading neuro-occupational therapist in the country, Dr. Steve Page back there? I just like to say that because it embarrasses him. And then he also asked me to do that. So I get $10 every time I do it. I'm just kidding. And then the student is really, they're driving this as best they can. So this is really about helping them facilitate their leadership, their ability to interact, and really helping to shape practice. So without further ado, Jordan and Rebecca come on down, and they're going to talk to you about their doctoral experiences. How about a nice round of applause? We did it alphabetically, so Rebecca, you get to go first.
Okay, so for my doctoral experience, I'll be here at Martha Morehouse in the Driving Center. And my proposed clinical question is, for young adults with a high-functioning autism spectrum disorder, is a new protocol based specifically on characteristics of autism more effective than an older adult protocol in predicting driver's readiness? So what that means is, right now they're using protocols for an older adult who's had a stroke or a minor TBI, and they're kind of just adjusting that based on clinical reasoning for individuals that come into the clinic with autism. So I'm trying to look into the literature and see if there's a better way to decide if individuals with autism are appropriate to go through driver's training. So my proposed components of my capstone are to, of course, create a clinical practice guideline based on literature for the facility to implement with clients that fit the target audience, to create an evidence-based driver's readiness checklist to give to parents of the young adults that are coming into the clinic to see if they're even appropriate for the initial evaluation, rather than just, like I said, using clinical judgment. Then at the end of it, I plan on disseminating the information obtained through the literature at a driver's rehab CEU under the guidance of my site mentor, and then also spread the word to other places that may have individuals that would benefit from the service. So maybe like Nationwide Children's, haven't really gone into detail with that, but that's the plan. And then surrounding school districts that may have students that would benefit from such service. And then of course to gain hands-on clinical experience with regards to OT's role in driver's rehab and assist in whatever clinical documentation, et cetera, that needs to get done. So, yeah.
How cool is that?
So I will be at Nationwide Children's for my doctoral experience. I have an interest in pediatric burn patient population. So my clinical question is, in a pediatric burn patient population, does casting in a position of stretch versus the current standard of care decrease the risk of contracture? So these are some of my proposed activities that I worked with my mentor to come up with. So I'm hoping to gain clinical experience in both inpatient, outpatient, and the burn clinic settings, gain training opportunities in casting, splinting, and compression garment fitting, possibly creating interdisciplinary education materials on casting, exploring additional outcome measures to, in addition to the decreased risk of contracture, such as caregiver burden, quality of life, etc. And then we're also going to look at exploring the effects of modalities with burn patients, and then early mobilization following skin grafting.
So we have 12 students in our first class, and all but one are placed, so we're still looking for one little NICU spot for one. But it's kind of cool to see the types of things that they are doing. We have a student that's going to be going to Botswana to work with an occupational therapist that was part of a group that was here last summer to look at creating a protocol for wheelchair use in third world countries, which obviously is different than other types of things we're doing. This is what I do. So why should you do this? Hopefully you can see that they're producing end products that are going to be great for the student, phenomenal learning for them, very different than a traditional level 2 fieldwork experience, but also to leave organizations with information that it's going to be really, really helpful for them. So you can see that Jordan, you know, in terms of being a PEDS burn therapist, which I think is how you want to spend your life. Thank goodness you want to do it. And so how great is that she's going to have these exceptional experiences. And Rebecca, in the same way, will have this really great expertise within autism across the board, but specifically for driving. So we think they're going to be great at providing you resources that are going to be great for your organization. Continuing education, access to faculty, or non-access to faculty, so if you don't want us involved, well, I have to at least talk to you at least halfway through or something like that. The other thing is really to leave a legacy, right? I think that's the really nice thing. Some occupational therapists have the ability to write and publish and present, but not all of us do. And so a lot of times when we retire, we have 30 or 40 or 50 years of experience that we build up through that. And this is a really nice way to be able to give back and to continue that legacy. And the other thing is really to both train this next generation of practitioners and to continue to grow the profession. So future direction for us, we passed both of our ACODE visits last spring, so that was good. We have 12 members of the current class next year, and the reason we have you here is we have 47 members coming in this next class. So recruiting doctoral experience sites right now. But we just got a site at the University of Michigan in their AT center today. Was that today, Erica? Anyway, today or yesterday. So that was kind of fun. So if you have ideas, I'm happy to talk to you. And there you go. So I think how you can help commit to be a mentor would be awesome.